I'm Brandon Smith, a primary care pediatrician, researcher, and assistant professor of pediatrics at the Johns Hopkins School of Medicine. I'm excited to tell you about a recent study that I presented at the Academic Pediatric Association Region 4 meeting in Charlottesville, Virginia. The title of our study is A Latent Class Analysis of Medical Needs and Social Drivers of Health in Bronchopulmonary Dysplasia. Bronchopulmonary dysplasia, or BPD, is a chronic respiratory disease in infants born premature that results from an imbalance between injury and repair in their developing lungs. Up to 50,000 infants each year are diagnosed with BPD, and each of those children face a lifetime of chronic respiratory symptoms, like recurrent cough and wheezing episodes. The earlier that we can identify risk factors, both medical and social in nature, for worse outcomes, the earlier that we can intervene and optimize lung health over the lifetime. Many studies have investigated how a single factor, such as smoke exposure, impacts outcomes for children with BPD. However, those analyses don't account for the multiple risk factors that a child has and how they influence outcomes when taken together as a whole. So instead, we used a person-centered statistical approach called latent class analysis to identify groups of children 3 years and younger with BPD, based on both medical and social factors. Looking across classes, we then compared the prevalence of chronic respiratory symptoms as reported by their parents. That included cough or wheezing, activity limitations, and nighttime symptoms. We utilized data from patients enrolled in the Johns Hopkins BPD patient registry, which began in 2008. Since then, the registry has enrolled more than 1,000 children with BPD from across the state of Maryland during pediatric pulmonary clinic visits. 10 variables were used to identify the classes, including factors such as the child's gestational age, medical technology use, and household income. We found that the optimal number of classes was 5, representing classes of children across a high, moderate, and low range of medical needs and social risk. Controlling for sex, race, and ethnicity, and insurance coverage, we then compared the prevalence of outcomes across all of the classes. We found that 2 classes consistently reported the highest symptoms. A class with high medical needs with moderate social risk, and a class with just moderate medical needs, but high social risk. Our study is one of the few to look at multiple risk factors simultaneously when investigating outcomes in children with BPD. And our results highlight how both medical needs and social risk together influence a child's outcomes. Our study could lead to a better understanding of the early life trajectory of lung health based on a child's full lived experience. And ultimately, more work with families is needed. First, through qualitative research studies to fully understand the family's experience in managing their child's BPD. And second, through co-created interventions that target both medical and social needs to reduce respiratory symptoms and improve lung health in early childhood. I'd like to take a moment to say thank you to the members of the study team for their contributions to this work, as well as the National Institutes of Health for funding this important and necessary research. I appreciate your time, and thank you for listening.